how we can even train our management in the requirements for IPC programs. But today, because it enhances the quality of the presentation. Without that, we may have problems with communication, so particularly mute your microphones. If you have any questions, and we hope you make note of questions through the presentations, please post them in the Q&A box, not in the chat box, in the Q&A box. And those that go into the box will be addressed at the end of towards the end of the session. So we don't answer questions, I'm afraid, in the chat box, as we can't respond to them. And so just to stress, please put your questions, and we really welcome questions into the Q&A box. So we have three speakers today. Ms. Susan Kessie from Africa CDC will give us an update on the status of COVID-19 in Africa. Then, as I mentioned, Dr. Landry Cabego from the WHO Afro. He's the Infection Prevention and Control Officer. And he will discuss Ebola and COVID-19, and if we have them both, how do we handle them together? And we will also have a representative from Liberia, who of course are concerned about resurgence again. So Dr. Salif from Snow from Liberia will also talk about the country perspective on Liberia. So thank you for all our presenters for being here. And we'll start the webinar by asking Susan to give us an update on COVID-19. Thank you very much.
Hi, hello, good afternoon, everyone, and welcome to the 6th series of Africa CDC webinar. I am Susan Kessie from Africa CDC. As of 9 a.m., 10th of March, 2021. This slide shows the global distribution of coronavirus COVID-19 cases. Globally, there are over 116 million confirmed cases and over 2.5 million related deaths, with case fatality ratio of 2.2%. The map to the left shows the distribution of cases by country globally. The darker colors indicate countries that have reported more than 1,000 to 1 million cases. The panel to the right is the epidemic curve, showing the trend of COVID-19 cases reported daily by the 6 WHO regions. Africa is currently accounts for about 3.5% of all COVID-19 cases reported globally. This slide focuses on Africa. The map shows the distribution of cases in Africa by country. The darker red colors show show countries that have reported more than 100 to 500 cases, for 500,000 cases. The graph to the left shows, the graph to the right shows the distribution of cases reported daily, and the red line shows a 7-day moving average. There are over 3.9 million cases and 106,000 related deaths, with case fatality ratio of 3.5, with the case fatality ratio of 2.7. That is Tanzania. 19 countries have more than 27 countries have 10 to 30 tests per case. 7 countries have 31 to 100 tests per case, and only 1 country has 100 tests per case. Thank you. Over to you, Dr. Prof. Valerie.
Sorry, I'm just trying to unmute. Thank you very much for that update. I think although we may only have 3.5% of global cases, COVID-19 still presents us with many challenges, and not least when we have a outbreak of information on Ebola and COVID-19, how we handle together. How did you manage that? Don't
Can you hear me?
Yes. You're still a little faint, but that may be my computer. I hope others can hear you.
Okay, thank you. I hope you can hear me better, but if you don't hear me properly, please let me know. So today I have a huge task to bring you through the transmission-based precaution in the context of COVID-19 outbreak. So at the end of this session, I hope that the participant will be able to define, to understand what is IPC and the purpose of IPC, to define a healthcare associated infection, to describe broadly the standard precautions, to describe the transmission-based precautions, to explain the different categories of transmission-based precautions, to select the appropriate transmission-based precautions according to the assessment of the risk, and to describe the measures to put in place for each transmission. Also generating procedures like bronchoalveolar aspiration, COVID-19 so this is what we call the airborne transmission. And this will have, when we are applying the IPC precautions, we need to take into consideration that additional mode of transmission. For Ebola, the main route of transmission, the main mode of transmission is by contact transmission. So when you get direct contact with infectious tissue or indirect contact with contaminated objects. And now we need to know what is the portal of entry into the susceptible host. And the portal of entry for COVID-19, we know, is the respiratory tract. As for Ebola, is all the mucus, even it cuts through the skin. And the last element of this transmission chain is the susceptible host. Immunized, the chain of transmission will be broken. So at the beginning of this outbreak, this pandemic of COVID-19, we saw that it's kind of a new strain of coronavirus, and nobody was immunized to them. So more or less all the population of the world was susceptible to this virus. And for each element of this chain of transmission, there is some that can be in place. For example, for susceptible hosts, we can immunize all the susceptible hosts. This is the role of vaccination campaign, which is starting. We can, for the medication or maybe with decontamination of the environment, we can isolate the reservoir. In this case, reservoir, if we notice that a human being is infected with COVID-19 or Ebola, we need to make sure that he is isolated in a particular room so that he's not going to transmit the disease to other people. So the first strategy to break the chain of transmission is what we call the standard precautions. Standard precautions are the basic level of IFC precautions that are being used for all the patients all the time according to the risk assessment. And here we have the different standard precaution. We have one of the main standard precaution is hand hygiene. And we know the efficiency of hand hygiene since Ignaz Semmelweis in 80s, and the role and how WHO and other agencies are really implementing hand hygiene in the region. We have also the respiratory hygiene to make sure that we don't transmit infection to droplets. We have the PPE. We need to wear PPE according to the risk. If we think that we're going to get in contact with biological material, we need to make sure, for example, that we wear gloves, gowns, etc. We need to apply safe injection practices. This, as shown, is efficiency when it comes to protect from blood-borne diseases like hepatitis B, hepatitis C, and in this case, for Ebola outbreak, we need to take into consideration this one. We need to handle properly and clean and decontaminate patient care equipment to make sure that the environment and cleaning is properly done, to make sure that we are managing well the linen, but also to make sure that all the waste that we're producing in a healthcare facility is being managed properly to avoid this continuous transmission. So as I said, when we're applying this precaution, we need to identify the hazard. And when we have identified the hazard, we need now to identify who is at risk. And then we evaluate the risk. And then we're going to identify what control measures we have to put in place. After discussing about the standard precautions that most of you really know, we're going now to discuss about the transmission-based precaution, taking always into consideration the two diseases that we are focusing on today, Ebola virus disease, as well as COVID-19. So we are going to talk about three types of precaution. The first one is contact precaution, which can be the contact precaution. The second, droplet precaution, and the third is airborne precaution. When do you use transmission-based precautions. We use in addition to standard precautions. So these transmission-based precautions include standard precaution. We need to know first standard precaution before applying the transmission-based precaution. And we apply them when a patient is or is suspected of having a confirmed infection with a highly transmissible pathogen. The pathogen is considered important for an epidemiological point of view, like SARS-CoV-19, SARS-CoV-2, Ebola virus, like all the multi-drug resistant bacteria. As I said previously, we are going to discuss about these three categories of precautions. Sometimes for some diseases, we can use a combination of precautions. This is the case for COVID-19, where we use contacts and droplet precautions, and sometimes we add as well airborne precautions when we are performing aerosol generating procedures. This gives us a picture on as I said previously, transmission-based precautions need to be taken into consideration after standard precautions. And these transmission-based precautions contain standard precautions, special accommodation like isolation. We need to take into consideration the signage that's informed of which precaution that need to be implemented, and PPEs, dedicated equipment, and additional cleaning. So for example, for somebody who has a particular disease that is transmitted via contacts, if you use an equipment like, let's say, an equipment that touch the patient, for example, a stethoscope or a tensiometer, and then you use it to the following patient, you can transmit the disease to the other patient. So it's recommended to have dedicated equipment to this kind of diseases. And then another element of transmission-based precaution is the limitation of transportation into the healthcare facility to avoid the transmission of the diseases. And we need to do proper communication, especially when we are working with other services. For example, you are sending a patient to do an radiography. You need to properly communicate with the other departments so they can put in place necessary measures to avoid the contamination. So as I said previously, isolation is one of the measures that need to put in place in case of COVID-19 and EVD. And before isolate, we need to make sure that we detect the suspect cases. And how do we detect? Via a screening triage system. When you have your case definition of the particular disease, and people who respond to the case definition, you need to bring them to an area where they will be isolated from other patients who do not respond to the case definition of that particular disease. This will protect the medical doctor, will protect the other patients and all the visitors who are entering in the facility. We use contact precaution when a patient has or is suspected of having an infectious illness that is transmitted by direct or indirect contact. Direct contact occurs through touching. An individual may transmit microorganisms to others by touching them. This is the case of Ebola. Or indirect contact occurs when microorganisms are transmitted via contaminated clothes of a person who is deceased from Ebola. If you don't handle them correctly, they contaminate them, they can transmit disease to other person. So when a patient is isolated, we need to make sure that there is some signage that is communicating which type of precaution that need to be put in place. And this is an example of a precaution sign that we can put on the door of a patient who is isolated. And here it gives us the type of precaution, which measure needs to be in place, and hygiene, wearing of gown and equipment to limit transportation and to have additional cleaning. These are the different elements of contact precautions. For healthcare workers, as I said, we need to have appropriate signs on the door. We need to put notation in the chart before entering the patient environment or having contact with the patient, and hygiene properly, that we wear our PPEs, gloves and gown. And after contact with the patient or the patient environment, we need to remove the PPE and clean our hands. We need to provide dedicated equipment, including thermometer, stethoscope, etc. And we need to make sure that there is a cleaning protocol in place. For the visitors as well, we need to guide them on what are the best precautions to put in place as well for caregivers. And so for the visitors, we need to tell them that how often they need to clean their hand and how well they need to clean their hand according to WHO recommendation. For the patient transport, as I said previously, we need to notify the required precaution, ensure that the patient hands are clean and disclosed as well. When do you use or having large droplets? So these droplets can have a diameter of more than 5 micrometer. So they cannot stay in the hair, so they fall down after being released through cough or sneeze. So the precaution that need to be implemented here is to make sure that there is a distance between the sick person and other person, but also when you get into contact with this patient, to make sure that you apply, you wear a mask and your face shield, face protection, you perform hand hygiene correctly, you have dedicated equipment, limited transportation, etc. Hello?
Hi, Dr. Landry. We seem to have lost your slides.
Oh, okay. I think there was a problem of connection. Can you hear me?
Yes, we can hear you.
And can you see the slide?
Oh, yes, that's fine.
Okay, thank you.
Thank you.
So for COVID-19, as I said previously, these are the 2 types of precaution that we need to implement. Before taking care of a patient, we need to make sure that we have our contact precaution as well as our droplets precaution. And sometimes we can have diseases that have been transmitted via air. And for these diseases, it's like for tuberculosis, measles, chickenpox, etc. We need to apply airborne precautions. And for this particular pandemic, as I said previously, COVID-19 can also be transmitted via air. And this is when we are performing what you call aerosol generating procedures, like and for this, we also need to make sure that we apply the hand hygiene. We have a special mask, certified mask, respirator, like the N95 or the FFP FFP2. So this is the only indication of wearing this kind of mask when we are taking care of COVID-19 patients. It's when we are performing this AGP, aerosol generating procedures. We need to make sure also the room where these patients are isolating has a negative pressure, so that we avoid the air to go to other rooms and to infect other people. We can put in place a natural ventilation, making sure that we open the window, air is going outside, etc. But other precautions like hand hygiene are still also important. As I said, natural ventilation for airborne precaution is very important, especially for our context. We can install a fan or other portable option to direct the airflow to the outside. We can keep the windows open and the door to the room closed. The option 2 is to keep the windows and the door open. But we need to make sure that when we are opening the windows and the door, they don't lead directly, they lead directly to outside. Otherwise, we need to keep the door closed. If they don't lead directly to outside, they can, the air can go to other departments and contaminate other people. So here we give the PPE for COVID-19 versus Ebola when we are taking care of these two type of patients. At the left is for COVID-19, and right it's Ebola. We can see for Ebola, as Ebola is transmitted via every type of body fluid, we need to protect all of our skin, body, mucous membranes, etc. So I guess that this is really an overview, and we have different, our participant has different background. I'm going to try to give a little bit how we can quickly organize a response of EVD and COVID-19 at national level to make sure that these precautions that we are suggesting are being applied efficiently at all the level of health system. The first thing that we need, if you are a manager at country level, you need to make sure that there is an IPC committee at national level. And this IPC committee is meeting, and this IPC committee will be responsible for coordinating partners that are implementing IPC in the country. We need to make sure that you have standardized evidence-based IPC guidance, SOPs and tools, tools for example, rapid assessment of healthcare facilities. WHO has the IPCAF tool, the Rapid Assessment IPC Scorecard, in collaboration with Resolve, ICANN, and Africa CDC. There is another checklist that we've developed that can quickly assess some key IPC measures in the healthcare facilities. So at the national level, we need to make sure that we have all these elements. The IPC committee at the national level needs to ensure that all the healthcare workers are trained in IPC, basic IPC, standard and additional precautions. We need to make sure that we have sufficient materials, supplies that can help to implement IPC. Because, for example, if you know how to do hand hygiene, but you don't have water or you don't have alcohol for hand hygiene, the compliance of hands hygiene will be very low. For Ebola, for example, you need to have some specific SOPs for self-identified barriers. So we noticed that during Ebola outbreak, many people were contaminated during burial ceremonies because the body is highly infectious And all the people who are touching the body are at risk to develop the diseases. For COVID-19, the body is not highly infectious, so you just need to apply your standard precaution. But what is the risk factor is the ceremony itself, because many people are coming to the burial ceremony, mass gathering, and this can lead to increase the transmission because of a poor implementation of physical distancing between all the people who are in place. We need to make sure that we decontaminate the facilities or the isolation area properly according to the guidelines. And for the decontamination, it's important to know which type of pathogen we are facing, because according to the type of the pathogen, we need to use different procedure, different concentration of disinfectants, etc. For our cases, COVID-19 and Ebola are RNA viruses, enveloped RNA viruses, and enveloped RNA viruses usually can be easily decontaminated. Then we need to establish at sub-national level, for example, in all the region, we need to make sure that we have IPC committees, as well as in all the healthcare facilities, we need to make sure that there is at least an IPC focal point or practitioner, it depends how you call him, and give him some type of references of what he needs to be doing. We need to conduct a cascade training for all the health workers. We cannot assume that health workers are applying the measures just because they're the measures. We need really to train them and to monitor what they are doing in the healthcare facility. There is this WHO multimodal strategy of implementing IPC in health facility that needs to be taken into consideration. It means first, the managers need to make sure that there is enough material in the healthcare facility. Second, the management to make sure that the health workers were trained. They need to put in place a system of monitoring and feedback. And this also, they need to put in place some reminders in point of care, and this can improve the compliance of IPC measures in these healthcare facilities. So there is sometimes we set up some specific centers to take care of Ebola patients and COVID-19. So the role of IPC committee is also to make sure that these treatment centers are well, the IPC is really implemented in these treatment centers. In the previous outbreaks, what we noticed, for example, for Ebola, was that people are always moving from one city to another, from one region to another. That was the case in North Kivu, where the Ebola was like in a triangle. It was going from Butembo, Beni, and Mangina. It was really like a triangle. When we finished the outbreak in one place, it moves to another place and then another place. It's the migration of people. They are moving. If they get sick at one place and they have family to another place, they will go to look they will go back to their family, and then they will contaminate people in that other city. IPC measures at a point of entry, you put in place some point of control, you do some surveillance at a point of control to detect all the suspect patients, so that you can isolate them, you can test them, and then you can notify to, you need to make sure to do a response to such of epidemics. Because sometimes in our region, the community doesn't really doesn't have the same understanding of things like us. There are people who were saying, for example, Ebola doesn't exist, it's not a true disease, as well as for this COVID-19. So proper strategy for communication so that you can show them how they need to protect themselves. And for this, you need to work with anthropologists, sociologists who can better understand the community and can suggest how to frame the messages according to the particular community. I'm going to give an example. For example, for Ebola virus, when we're doing self-identified using black body bags, and the community didn't want us to use these body bags. And when we discussed with the community, they said that they don't want us to use a dark bags. So we had to buy other type of plastic bags where we put the body that is transparent, where we can see the body through these plastic bags. So you need to understand what. And lastly, we need to ensure that there is coordination with AP teams, surveillance. We need to make surveillance of health worker infections, to track them and to monitor them and to respond according to the gap that has been detected in the facility. So I hope that I have covered more or less the different aspects of this presentation, focusing on the transmission-based precaution of the two diseases. Thank you, and over.
Thank you very much, Dr. Landry, for your excellent presentation and clearly presenting the whole that's needed to control both these infections. I think one of the slides and the PPE required for COVID-19. Because today people are still using PPE that was left over from Ebola in managing COVID-19 patients at considerable cost. So I think it's important to understand the difference between the two. And I think you clearly showed that. And if you have any questions where you're unclear, please put your questions in the Q&A box for Dr. Landry, because there'll be time at the end to ask these questions. So thank you. And can we move on to our last speaker, Dr. Zainab Sirleaf-Snow, who is the National IPC Officer in the Liberia WHO Country Office. And he's looking at the country perspective from Liberia on Ebola and COVID-19. So let me hand over.
Okay.
There we go.
Okay. Good morning, good afternoon to all. Can you hear me?
Yes, thank you. We can hear you clearly.
Okay, I'm Zainab Snow.
Could you put your slides on full screen?
Okay, just a minute. Sorry, I'm having problem.
If you just click on your bar from the beginning, should. You had your arrow on the top bar. So either click from the beginning or where it says from current slide. Does that work?
Say that again.
If you move your cursor to the top bar and go to from current slide. The one below, sorry, one below.
I'm sorry, I'm not getting it.
No, don't worry, just keep going. Thank you.
Okay. So basically, I was asked to give a brief update on COVID-19 response and EVD preparedness. So for our outline, I'll be giving the updates, COVID-19 preparedness activities, COVID-19 response activities, EVD preparedness activities, lesson learned from EVD outbreak, COVID-19 and EVD triage tools, some challenges and next steps. So we experienced COVID-19 from 16 March 2020 and we are still in response mode as of 7th March 2021. So Liberia has reported 2,026 confirmed cases, 13 deaths. The case fatality rate is 0.64% across the 15 counties. Macerado County is the county in which we have our city center, Monrovia, carries the highest burden, which is 76%. We have had 224 healthcare workers infections confirmed, which accounts for 11.1% of healthcare workers that are infected. So as of this moment, we are still responding to COVID, like I said previously, and most of the confirmed cases are coming from travelers because we have this mandatory testing before you leave the country. You have to get tested. So most of our confirmed cases are now coming from those being tested before traveling. So for COVID-19 preparedness activities in Liberia, we conducted rapid health facilities assessment in all of the 15 counties. We cover 48% of the healthcare facilities in the country doing our RIGS assessment, our healthcare facility rapid assessment. This assessment was actually done to, have an informed decision making on the various IPC standards at those facilities levels. We conducted the county, district, and healthcare facilities IPC inventory for informed decision making, so as to make us understand where and what we need to pre-position at those various healthcare facilities. We adapted several tools from WHO guidance documents, ranging from guidance documents for banking institutions, for pharmacies, for market, for schools. We identify and train surge capacity for IPC during the COVID-19. Those surge capacities that were identified were trained and they were deployed in Macerado County to conduct monitoring and supervision in all of the healthcare facilities in Macerado County. We also conducted assessment and strengthened IPC practices in the routine health care services. So doing this activity, we try to conduct hand hygiene audits, the FCAP reassessment. We reinforce and strengthen all of the quality management teams at the healthcare. IPC standards and practices are monitored. So during the response, we were able to train 22% of our frontline healthcare workers in COVID-19 specific IPC measures. 600 of the 872 healthcare facilities were monitored on a daily and weekly basis in the country. We had essential IPC supplies distributed to the COVID-19 treatment units, the precautionary observation centers, and to the healthcare facilities. We also conducted healthcare workers' risk assessment for those healthcare workers that were exposed. And then we ensured that all homes that COVID-19 confirmed patients were in the health facilities were disinfected. To strengthen the triage practices at all of the healthcare facilities, we trained healthcare workers, basically medical students, and they were deployed to all of our hospitals to ensure that the triage process was strengthened and they were ongoing. We continue to monitor and supervise the schools to ensure that IPC practices are ongoing since schools are already open. 700 teachers of those high schools and universities were trained on basic IPCs. So for lesson learned from EVD 2014 to 2016, we had several lessons that were learned to prevent upcoming outbreaks. We learned that the culture of IPC needed to be established in our routine healthcare delivery system. So to do that, the Healthcare Quality Management Unit of the Ministry of Health was birthed, and then a director of that unit was appointed along with support staff ranging from IPC coordinator, quality assurance coordinator, clinical coordinator, etc. We also wanted to decentralize the IPC program to the subnational level. So to do that, we recruited IPC focal persons for all of the 15 counties. They were trained and deployed to monitor IPC standards and practices in the county. The same with the healthcare facilities. Healthcare workers at the various healthcare facilities were designated, trained to ensure that IPC practices and standards are adhered to and monitored. They are also charged with the responsibilities to ensure that refresher trainings are ongoing at their various levels, and all of the reports are then sent to the national level. To institute IPC practices, processes, and structures, we also learned that we needed isolation facilities, and we needed to ensure that the triage process are ongoing. So to ensure that that happens in the country, we had UNOPS in collaboration with the Ministry of Health constructing isolation facilities at some of our counties' hospitals. And those facilities also ensure that the triage process is ongoing and people assigned to ensure that every patient entering the facility are triaged. IPC ring approach, we learned, is also an effective way to control the spread of individual cases in cluster. So all the time when we are responding, we ensure that the ring approach is activated so that we can ensure that the spread of whatever disease we are combating, be it Ebola or COVID-19, is being contained where it started from. So we also learned that timely multi-sectoral intervention facilitated IPC standard rollout in all of our healthcare facilities. So lesson learned. Practices in all of our healthcare facilities and at all levels. We also learned that it is crucial to maintain essential health services during disease outbreak. Now, during the EVD outbreak in 2014, From the very inception, healthcare workers, we did not understand how to combat EVD. Healthcare workers were not trained. We did not know the recommended PPE at the time. WHO, along with other partners, came in to render assistance to the country. So because of fear, we have patients dying from pre-existing comorbidities because healthcare workers really did not know how to, read whether this person have. They didn't know the actual case definition. They were just afraid to admit every other person. So people died because of that. So we have learned to see how our system can be resilient in working, in responding, as well as ensuring that the routine health services and the core functions of the health sector can continue, like vaccination, surgeries, and other patients that have different disease conditions, that they can be attended to and their lives can be safe. So effective coordination across pillars and at all levels of the healthcare system, the national, the county level was critical, because we know that when the various response pillars are not coordinating, there will be a lot of miscommunication and we won't be able to contain the outbreak. So we also learned that some measure of IPC principles and skills were essential. So to ensure that that also happened, WHO, in collaboration with the Ministry of Health, as well as WHO HQ, developed an advanced IPC package, and 65 of our IPC focal persons were trained and also sent back to their various counties to ensure that the advanced IPC training package was rolled out. IPC implementing partners need dedicated responsibilities. So as Liberia is, our country is heavily relying on donor, the health system. So most times we have outbreak, we look up to the WHO, the other partners that are involved in IPC to ensure that we have supplies, we ensure that healthcare workers are trained and refreshed, that monitoring and supervisions are ongoing. So we also learned that when partners pull out, the system tends to relax. So we have encouraged the healthcare quality management units to ensure that all of the activities that are conducted are owned by the Ministry of Health, so that when the partners pull out, the capacity is already being built, and the country know exactly what to do when it comes to preparedness and response activity as it relates to the IPC program. So as you all know, Liberia is bordering with Guinea, that is presently dealing with the EVD outbreak. So definitely the country is at a threat. We have several borders, porous bordering with Guinea. So for us to prepare adequately, we already have our ICAF with our various SOPs, protocols, job aids. So the team met, reviewed, we updated those SOPs and protocols. They are printed now. Distributions are ongoing to the various healthcare facilities. WHO was able to procure some essential IPC supplies, and they are already being donated to the Ministry of Health for distribution to the healthcare facilities. Currently, we have an ongoing rapid healthcare facility assessment at counties that are actually bordering with Guinea, and those health facilities that are proximal to the border. We are working now with the ministry to see how we can strengthen IPC at those various locations. So from the IPC rapid assessment that is ongoing, we have preliminary results that we want to share briefly. So we have perimeters that were assessed when we went to the facilities. We assessed for screening and triaging. We assessed the isolation and holding area to ensure whether they are available. We assess the availability of PPE and how they are used. We assess IPC practices, conducting simulation exercises, and those practices ranging from standard precautions. We conducted simulation exercises to know whether our healthcare workers are still abreast, and to also ascertain whether they need refresher trainings. The referral pathways were also assessed, and we will see that we have overall average from all of the various perimeters that were assessed. So for the 6 counties, the overall from the perimeters that were assessed is 66%. This activity is still ongoing. I just thought to share with the team. So for the 6 counties that we conducted rapid assessment in, these are the results of the various indicators that were assessed. We see the highest score that we have is 84%, and the total score is 70%. This activity was conducted in 25 health facilities for now, and the team continued to go to other facilities to continue this activity for informed decision making. So as you can see here, these are the scores per facilities that were visited during the rapid assessment last week. So we have few challenges as a country. We continue to experience poor stock management and inventory. We are working with the Ministry of Health and the supply chain system to see how we can strengthen this year. We already started to develop some tools, database, to see how we can track the various IPC supplies. As usual, we have limited IPC supplies in country because the country, like I said, is heavily donor dependent. Isolation holding area is limited at healthcare facility level. We still need more of that to be erected. Poor monitoring of IPC standards. Right now, there's situation, the knowledge and skills are there, but to visit the various facilities need logistical support. So at the moment, the various county health teams are struggling to see how they can have logistical support to continue monitoring and evaluation at the various healthcare facility level. So staff demotivation and weak IPC culture. So majority of the staff are not dedicated. So that's one of the complaints staff will have. They're not dedicated IPC focal person. So they are doing dual jobs that they are not paid for, but the system is working to ensure how all of these problems can be resolved. So we have several next steps for our EVD preparedness is to actually continue the rapid assessment complete and have a whole report that can be shared with stakeholders for informed decision making. Another next step is to organize a teleworking section with the county IPC focal persons to present and discuss the implications and application of the findings from the rapid assessments. We're going to adopt IPC modules for COVID-19 and EVD vaccination and see how we can train our healthcare workers, conduct refresher training for healthcare workers from selected counties. We will continue to advocate for infection control supply and ensure that they are distributed to the last mile. We will continuously support health facility monitoring and supervision activities. So these are some pictorial from the recent health facility assessment and border assessment by the Healthcare Quality Management Unit and WHO teams. Yeah. So thank you for the opportunity.
And thank you very much for a very interesting presentation. I think it's very helpful for us to know how you're managing with this new, with the new cases of Ebola and managing COVID-19 situation as well. So now we have a number of questions in our question and answer box. So I'm going to hand over to Dr. Wendy to manage this session, and we'll see how many questions we can get through in the time remaining. So Wendy, over to you.
Fantastic. Thank you so much, Prof. Val, and thank you very much to our participants. We see very interesting questions already on the Q&A chat. We are also streaming this live on our Twitter and our Facebook pages. And thank you, colleagues on those platforms. Keep your questions coming. We'll do our best to address the questions. Today on my panel, I have experts from Africa CDC, from ICANN, from US CDC, and also from WHO Afro, and of course our country representative from Liberia. We will do our best to answer your questions. I think I will start off with some of the questions that I can see, and I will start this off with Landry. I think I'm going back to things around the transmission-based precautions. There's a question in the difference between how the Ebola virus and the SARS-CoV-2 are transmitted in the body. I know you said that, but I think we need to reiterate the clarity in terms of how these viruses are transmitted. Over to you, Landry, for that question.
Sorry, Wanda, can you repeat, please? I didn't really catch the question. Sorry.
Sure, no worries. The question is just to differentiate sort of the transmission of Ebola virus and SARS-CoV-2. If you can please just reiterate to the participants how these two different viruses are transmitted in the body, so that at least the use of PPE.
Okay, thank you. For SARS-CoV-2, the transmission, the main route of mode of transmission are contact transmission and droplet transmission. If we get into contact with respiratory secretions, and we can get infected. So this droplet needs also to, we can touch, for example, a surface that is contaminated with respiratory secretions that is containing SARS-CoV-2, and then with our hand we can also touch our nose mucous membrane, and infection can start from there. So these are the main route of transmission. For Ebola, the main route of transmission is the contact transmission, which can be direct or indirect. And for Ebola here, the virus can be found into tears, sweat, urine, feces, blood, in all these body fluids. So any contact with these body fluids can lead to the infection if the virus enter into the body through cuts, through mucus, any type of mucus. The mouth, nose, eyes, ears, everywhere. So that is the difference. Well, through PPE, because any cut through the skin, contact with infected material can lead to infection. As for COVID-19, it's only through if materials enter through the naked membrane of
Dr. Landry, you're fading.
Okay, I'm fading. So I think that's in summary for Ebola, we need to be fully protected, because we need to be fully protected, wearing full PPEs, because the virus can enter from all the mucous membrane or any cut through the body. But for COVID-19, we need to wear specifically the mask, surgical mask, to protect the eyes, and to wear gloves and gown. This is sufficient. And I saw there was a question around the dead body. The dead body for COVID-19 is not infectious. But for Ebola, the dead body is highly infectious, because we can find the virus in the sweat, in the tears, in the urine. Usually when you find a dead body, I'm going to give an example. If you enter in a place, normally in DRC, for example, there were many dead body in the community, people who didn't want to go to the hospital, and they died in the community, in their bedroom, on their beds. So how do you find them? You find them, there is some blood, there is urine, they've urinated, there is feces, there is all this kind of body fluid. So you need to make sure that you don't get in contact with these body fluids. You need to be fully covered, because you can get into contact anywhere. So I think that I've more or less answered to these two questions. Patient visited during you need to identify contacts of that patient in these places. You need to disinfect these places. You need to make sure that you implement IPC in these places, because the new cases that you'll have will probably come from these public places, these households inside the ring. So basically, these are the principle of the ring. It helps to quickly implement IPC measures in high priority places according to the risk of.
Thank you very much. So I think I will move to, I see a number of questions that makes us step back and think around issues on ventilation, how healthcare workers should act or protect themselves in very congested places. So this question, I think I will be throwing to my colleagues from ICANN, Prof. Val. I think this question you might be able to provide some guidance on. It's just around an active case of COVID-19 with cough and sneezing in a room with no ventilation. Can we start to think around airborne transmission? Is this a form of aerosols? It's a two-in-one question. And also, can we use any type of fan for ventilation in case of airborne precautions? I think this person is just wondering if we can make the rooms a bit ventilated by using fans, which is a no-no. But Prof. Val, I'll let you talk a bit about those two, and then we move to the next few questions. Over to you.
Okay, thank you very much. I think if you have a patient in a room who is coughing, you should probably and there's no ventilation, you should move them out of that room as soon as possible. It's really important to have well-ventilated areas. And if you have a triaging system within your health facility, then you can move coughing patients into, you can even cohort them, you can move them into an area where they're less or if they have TB, to other infections have not gone away. So we need to look at well-ventilated areas. And if you don't have them, you need to find outside areas that you can use, look at alternative areas. I think Dr. Landry emphasized the need for good ventilation. We don't have mechanical we don't have situations where we have well mechanical ventilation that can move air around unless you do use fans. But when you're using fans, you really need to make a tube. So place them in a position where they move air to the outside. And as Dr. Landry said, make sure when air is moving to the outside, they're not moving into inside space, so into the outside air. So I'm just trying to think. I know Prof. Ogunzola is on the call, so maybe she can add to what I've said. But we always, also, if you have a crowded space, you really need to try and introduce measures that would decongest an area. So if you have an outpatient stay where lots of people are coming, they're all sitting close together, obviously that's a good way of transmitting infection. So again, triaging patients is really critical, so you can separate out potentially infectious patients from those who might get infected. And really look at what we've done in some of our district hospitals. We built shelters relatively cheaply outside where people can wait. And even if it's raining, they don't get wet, but they separated out from other patients. So I hope that helps. Thank you.
Thank you. And Elizabeth, I see your hand up. I just had a question for you. So in addition to that comment you want to make, I think it's going back to things around SARS-CoV-2 and the type of mask that should be used at community level. So if you'd like to answer that question in addition to the comment you had for the previous question.
Oh, sure. Thanks so much, Mwande. So I want to build off of the question, first of all, on ventilation. One of the worst things you can do is have one of those overhead fans that all it does is recirculate air within a closed space, because all you're doing is then moving around anything that might be airborne or aerosolized into a larger area in that space. So the last thing you want is one of those overhead fans that just recirculates the air in the same space. If you're going to use a fan at all, make sure to use it as Prof. said. Make sure you use it so the outside air pointed so that any air to the actual outside environment. With that, the question of masks is an excellent question. It really does differ. I mean, first I want to give a nod to different countries have different recommendations for masks. In the US, at least, we recommend a cloth mask at a minimum. But again, it varies by state in the US. But general recommendation is a cloth that should be anywhere, ideally 2 to 3 layers for that cloth mask, so that you're not relying on just one layer to stop. But a cloth mask would be acceptable in the community setting. For medical settings, we in general recommend, but again, this varies from country to country, state to state, a medical mask, a surgical medical mask. One of the most important things with the mask, though, is a good fit, wearing it over their chin. So it's a combination of making sure you have the correct layers and then also making sure that you're correctly putting it on your face and that it's nice and tight so that extra air can't come in. Over back to you, Wanda.
Thank you very much for that. I think that's really interesting. And this question, I think I will ask it's really interesting because it's something that I know that Landry and the team from his side and Africa CDC have really been looking at. It's around, and this comes from Prof. Shahin, is what can be done when there is no national IPC program, but only IPC of consent to both of our organizations and thinking about how we can support our member states to ensure that almost every country across Africa can have national IPC programs. So over to you, Landry, if you want to talk a bit about that, and I will try to wrap up with the answer.
Thank you, Wande. Thank you, Prof. Shahin. Unfortunately, in our region in Africa, in many countries, we don't have national IPC national program. That's the sad reality that we are facing. But when there is that is starting, IPC task force at a national level, and this task force for this particular outbreak national program to coordinate all the IPC activities in the country. But we really right now recommend to all the countries to implement national program, and know that WHO and partners, Africa CDC, ICANN, we are really pushing for that to make sure that all the countries have this national program. And maybe Wanda can speak about it. Africa CDC has developed a legal framework for IPC. I think that will be submitted to the African Union. And I think this is a very key moment of we'll have now to work together so that to support the country in the implementation of IPC program at national level. I think that will be the next step that we will be going on.
Thanks so much, Landry, for speaking on to that. And yes, indeed, you're correct. At the African Union, I think one of the things that we are trying to do is advocate at the very highest level to ensure that all countries have some sort of national programs beyond outbreaks. How can we keep our healthcare facilities safe? How can we ensure that we have patient safety? How do we protect our healthcare workers beyond reactive? When there's an outbreak, you start to see all of the IPC measures in place and things like that. But beyond outbreaks, how can we ensure that anyone going to healthcare facilities are protected? How can we ensure that healthcare workers are protected? So we are really looking to ensure that we advocate at the highest level. And beyond that, we're looking to work with our partners, Afro, ICANN, Resolve to Save Life, US CDC, among many others, to ensure that we are able to support countries to set up their national IPC program. Interesting discussion. And just because of the sake of time, what we usually do is all of the questions that were asked that were not answered, our facilitators and our presenters will be able to provide some of these responses, and we will put it in the community of practice. If you check on the chat, there's a link for the community of practice. I think it's going to be sent again just before we wrap up. This community of practice, you can ask all of these questions, and our facilitators and our experts will be able to provide you with some of the answers. The link for the Afro scorecard will also be sent along with the presentations for today. So on that note, I'd like to say thank you very much to colleagues for joining us on this webinar session. It's the first of the series, and remember that to get your certificate, you have to partake in at least 4 of the sessions, and you have to stay for the whole session so that you can get your certificates for this course. So on that note, we look forward to doing this again next week, same time. Please feel free to join. And next week, we'll definitely have the Arabic and Portuguese interpretation, and we definitely will be able to answer more questions next week. So thank you. On that note, I say goodbye and have a lovely afternoon.